there. Thanks for listening to Let's Talk Withdrawal, a weekly discussion on antidepressants and the issues surrounding them.
Hello, this is James. Welcome to episode 21 of Let's Talk Withdrawal, a weekly podcast discussing antidepressants and mental health. This week, I'm honoured to have had the chance to interview Doctor Gary Sidley. Dr. Sidley worked within NHS mental health services for 33 years in a variety of nursing, psychological and managerial roles. In the 1980s, he was employed as a psychiatric nurse at a large asylum in Manchester, commencing his clinical psychology training in 1987. Subsequently, he worked as a clinical psychologist in community mental health services, inpatient units and GP practices, as well as in senior management positions. Gary is now a freelance writer and trainer with an interest in promoting alternatives to biomedical psychiatry as ways of responding to human suffering. In 2015, Gary published the book Tales from the Madhouse, in which he clearly lays out the scientific evidence against current psychiatric practices, going on to illustrate key points with beautifully written, poignant, at times deeply shocking stories from his years of experience. His stories leave us in no doubt that medically led practices impact negatively on those in the care of mental health services. Tales from the Madhouse challenges us to question blind faith in psychiatric services in the UK. I was keen to ask Gary about his own experiences of working within the psychiatric system and what the future holds for mental health care. Dr. Sidley, thank you so much for talking with me today. Firstly, for the listeners, could you give us a little bit about your own background and how you came to be working in the psychiatric system?
Yes, it goes back quite a long way, James. I first started my career in mental health back in 1980, many years ago, when I got a job as a unqualified nursing assistant on an acute admission ward. I'd just left university the year before with a biochemistry and physiology degree, so I was quite into the science at that time. But during that degree, I decided I wanted to study psychology and become a psychologist. So after completing that degree, I thought I'd better get myself some relevant experience, and I managed to successfully apply for this nursing assistant's job on an acute admission ward. And then the year after, went to do my psychiatric nurse training at Prestwich Hospital, a large psychiatric hospital in Manchester. And I worked as a psychiatric nurse through the early 1980s up to 1987. And that's when I left to do my clinical psychology training, and then worked as a clinical psychologist from 1989 right through to my early retirement from the NHS back in 2013. And during that time as a clinical psychologist, I worked in a variety of roles, mainly in community mental health teams, some inpatient work, some in primary care psychology work as well, and also worked as a team leader and on a senior management team in my later years.
Thank you. Well, you've clearly worked everywhere, right from the coalface as a psychiatric nurse to senior management within the mental health care system, haven't you?
Yeah, I think I probably have. And I talked with someone else a couple of years ago now about like a personal journey through the system, really. And in my case, I think my journey can be divided into three chunks. I think in the first chunk, which is going back to my 1980s when I was nursing, I kind of saw myself as colluding with, when I look back on it anyway, colluding with the traditional psychiatric system. You know, I worked in a psychiatric hospital. I was involved in administering drugs, even involved in the ECT process, electroconvulsive therapy process at that time. And then I went into a second phase, which was probably around the 1990s onwards, where I had this belief I could have some impact from working within the system and trying to work with good, with pockets of good practice and seeking that evolution rather than revolution that people often talk about. But then by the time I got to the year 2000 and beyond, I was becoming increasingly frustrated. And I did, from that point onwards, recognise the need for a paradigm shift in the way we respond to human suffering.
Yeah.
And so in a way, my involvement with mental health does seem to divide up into those three chunks when I look back on it anyway.
Thank you, Gary. And given that range and breadth of experience, I just wondered if there was one anecdote that stands out for you that sums up your feelings about the modern mental health care system.
Yeah, there are quite a few, James, really. Quite a few anecdotes, many of them in the book. If I could highlight two quickly. One is specifically about antidepressants, and that was, I remember, this must have been probably 2003, 2004, maybe a little bit later, working in a community mental health team with a lady who had been struggling with a very, very low mood, feelings of hopelessness. And to cut a long story short, I've been working with her with psychological therapy in the community mental health team at a community mental health centre. And I always remember seeing her, I think it was probably about session 4 or 5, when it felt like we had a really good session. We seemed to make some breakthroughs in making sense of how she came to feel so low and so hopeless about things. We started to what felt like a genuine collaboration with her towards looking at what she might do.
Yeah.
Not just in the therapy session, but outside of it, to start to perhaps gradually move things forward. And we kind of came up with a plan between us that involved her becoming a little bit more active in the subsequent week between that session and the next one. And she was going to approach her current employer, because she was off on sick leave at that time. She was going to negotiate some graduated return to work, starting at some point in the future, not at this moment, but some point in the future. And she came up with some what seemed like really constructive tasks and some additional things she was going to try and do in the week. And she actually left the session with a spring in her stride, which was really, really encouraging. Sadly, the week after, when I met up, she seemed like she'd slipped back quite a lot, and this was a little bit puzzling. When I explored it, what seemed to have happened is that she left my office, or my room that I used at the community mental health centre, after what seemed to be, and what she acknowledged to be, a kind of really upbeat, positive session. An hour later, she had an appointment with our consultant psychiatrist, which was 2 doors down the corridor from where I was seeing her. And during that consultation with my psychiatry colleague, she was told that she must take things really easy now. She's got a depressive illness. She must reduce her activities, take the antidepressants and wait for them to, and their word was, to kick in. And that really struck me. One of the things that really struck me is how incredibly confusing that must be for our service users to get such conflicting messages in the space of one afternoon. But just the clash of paradigms, really, and how things often do kind of work against each other.
Very much so, and it's such a disempowering message to give someone, isn't it? That actually you have a chronic lifelong illness and your best bet is to be passive and let something external to you, like a medication, do something for you.
That's right, James, yes. And the poor lady mustn't have known whether she was coming or going, really, and what to do for the best. And so that's something that was a kind of little anecdote that did stay with me. Another one, if I can just share this one with you, this one in a way is even more powerful for me, and illustrates, I think, a lot that's wrong with the traditional Western approach to mental health problems. And this was a gentleman who, in his 40s, who had suffered an episode of acute anxiety and had acquired the label as of paranoid schizophrenia. Had been given to him back in 20 years prior to when I met him, when he did apparently become very suspicious of others, but it was in the aftermath of him being violently assaulted and robbed in his own flat. So it was kind of we might regard as not an unusual kind of reaction to such a traumatic life experience. But anyway, 20 years later, he came into contact with our community mental health team, and with something that was more around feeling quite anxious in social situations and having a very restricted life. He was a very bright man and lots of qualities, but seemed to be living and was living what's, by his own admission, a very restricted lifestyle, with very few friends and withdrawn from pretty much any kind of engagement with the community around him. And again, I was working with him with a psychological approach for some time, and we didn't seem to be getting very far, which always seemed a little bit puzzling, because he clearly seemed to understand the stuff we were doing in the session and seemed to understand the model and buy into it and seemed really enthusiastic about it. But we never, in between sessions, nothing ever seemed to shift. And then, again, to cut a long story short, one day he kind of shared with me what was clearly the reason for this. And this was that he was actually scared of emotion. He was very frightened about the prospect of him becoming emotional. So as a result, he avoided things that could actually trigger emotion, even positive ones. So he didn't want to enter into any relationships with women again, because he thought that might affect him emotionally. He tried not to get excited about anything, even to the point of not watching sport on TV because of his concern about getting kind of aroused and more emotional. And the origins of this, after some quite lengthy discussion, which he explained to me that back when he got his paranoid schizophrenia label, he'd been told by the psychiatrist then that he did have a genetic brain defect that could be activated by stress. And he'd taken that as being paramount of some internal explosive incendiary device in his head that could be triggered should he get emotionally aroused at any time.
That's an understandable reaction, isn't it? To remove all of the joy and happiness out of life just to try and protect yourself from something that you've been warned about. That clearly would lead to a very limited experience of life. That's so sad, isn't it?
It is, and that impacted on me greatly when I heard that, because that just seemed just so sad, that he'd restricted his life for so many years, largely based on that premise that any kind of emotional arousal would sort of detonate him into some florid psychotic episode. And that was quite a turning point when we started to discuss that and started to look at other ways of making sense of his experiences other than labelling it as a biological, genetically based illness that he was suffering.
And Gary, did he make progress after that? Did he get past that limiting belief?
He did after that. Yes, he did. He was a gentleman with a lot of skills and a lot of ability and intelligence, and a very able man in many ways. And yes, after that, he did start to reintegrate and did start to have friendships. He was cautious. He was dipping his toe in the water, as you can expect and imagine. But it was a turning point, and it just always stayed with me, James. Just what a burden to carry around, this idea that you've got some kind of genetic vulnerability that's like a ticking time bomb in your head, waiting to be activated by the challenges of life, or even by, in this case, positive emotion.
I can see why someone would go to great lengths to suppress that, but it's almost removing any chance for them to have a meaningful life, isn't it?
Quite, yeah. So that was an anecdote that's stayed with me, and I still think about that a lot to this day.
Thank you so much, Gary. Those stories really illustrate that tension that you were feeling between the biological, medication-centered approach when compared to a more person-focused, compassionate way of understanding distress and trauma. Gary, if it's okay, I wanted to move on to ask about your book, Tales from the Madhouse, which was released in 2015. Can you tell us what led you to write the book and what response you had from the medical community?
I think, broadly speaking, there were two main reasons for writing the book. I think the first was that it was an opportunity to express some degree of frustration and discontent with the way things were. So I think by the time I did leave the service, when I did opt for early retirement in 2013, I was feeling very frustrated and quite angry about some of the things that were going on. So I'd be dishonest if I didn't say there was a cathartic element to writing the book. But the main reason really was that I wanted to make some contribution, no matter how small, to trying to energise us towards some radical shift. It just seemed appalling that we were responding to people in distress in the way that we were, and I just thought there was much better ways we could do it. So I wanted to make my little bit of contribution towards trying to achieve that. So I suppose those were the the two main reasons for writing the book, James. As for the response to it, I haven't had a huge amount of negative response. The reviews up to date have been on Amazon have been very positive. Occasionally on social media, and I'm sure you can identify with this as a person who's active on social media. And obviously, there's been one or two individuals who are more wedded to a traditional approach, biological approach to mental health, who challenge me and accuse me of various things. The usual ones are to trying to be a bit of a self-publicist and seeking fame. Turf wars is another one, trying to reduce it to. In fact, I got called that about 3 days ago. Actually, that was my motivation. Turf wars. Which is really odd because I've been quite critical of my own clinical psychology profession quite a lot really as well. Yeah. So it did seem a bit perverse to call me that. And some of my particularly the American associates that I have on social media, there's been times when they've accused me of being a Scientologist, which was interesting because the first time I was accused of that, I didn't even know what a Scientologist was. I had to go and look it up. But after saying that, that criticism has been pretty limited, really. Most of the reactions I have received have been very positive. Yeah. Clearly, there's going to be a lot of people who are not quite on the same wavelength who probably just ignore it. I'm sure that happens. Hope it goes away. But as far as active opposition and antagonism, I haven't had that much, really, surprisingly.
Thank you, Gary. And, my view from reading the book is that there isn't really that much room for criticism because it's based on so much experience within the psychiatric system. Even in the introductory section, you even say that you would welcome people's challenge to your views and you're quite happy to engage in discussion. I think that's very brave.
Oh, thank you. Yeah, one does one best to keep an open mind because discussing this again with a colleague quite recently about in an area as contested as mental health, you've always got to retain the possibility that you might be wrong. Which is, I know I can be as opinionated as the next person, but somewhere in the back of your head, you've always got to retain the possibility that you just might be wrong.
I agree, and what I'd say in my own experience is that the difference between a good psychologist or psychiatrist and a bad one is that the good ones are prepared to admit that they may be wrong and have doubts, and the bad ones are those that are absolutely convinced that their way is the only way.
Yeah, I'd agree with that, and that was the way I see it as well.
Thank you, Gary. And I just wanted to move on now to talk about the current view of the world, if that's okay. In particular, I was interested in your view of the current use of psychiatric medications, particularly given the fact that the number of antidepressants prescribed has doubled in the last decade in the UK, and no doubt there are similar increases in many parts of the world.
Although I'm often critical of the way medication's used in the mental health service, I do accept that there is a role for medication. I'm not totally anti-medication by any stretch of the imagination. I suppose for me, James, it's about ensuring that the individual has an informed choice, and I know that's a bit of a well-worn phrase, isn't it? An informed choice, but for me, there are three key elements to ensuring that somebody has that informed choice. I think the three things I think people need to be aware of is, first of all, the efficacy of the antidepressants. As I've said, clearly they are of benefit for some people, but as you will know, the efficacy when we look at the studies that have pooled all the data together, the efficacy is quite limited overall. Yeah. Obviously, within that huge group of people, there'll be a lot of variation. Even that study from last month, the Jacobson et al. Study that was published last month. Which was this huge meta-analysis looking at all the different studies of the effectiveness of the SSRIs. Their conclusion was that there may be some statistical significance around benefit, so some quite small statistically significant benefit, but often that wasn't of any real clinical significance. Again, they always there are lots and lots of people within that group, and some probably will benefit a lot more than others. But looking at the picture overall, the efficacy isn't huge, let's say. And I think people need to have a realistic expectation of what the likely degree of efficacy is. So that's the first thing I think people should be clued upon, is the efficacy data. And of course, it's side effects and discontinuation effects, or the common side effects of taking antidepressants, but also, and perhaps even more importantly, the withdrawal effects that may well occur if you've been on them for a long time. And I think that those discontinuation effects to me are something that are quite striking, because I can recall back in the 1990s listening to psychiatrists and drug representatives coming around selling their wares to us, at least to my psychiatric colleagues, who were adamant that there were never any withdrawal effects to antidepressants. I remember them saying over and over again, these antidepressant drugs aren't like Valium and these terrible benzodiazepines. They don't have, you can't get addicted to them. There's no withdrawals. And yet we know now, of course, that there is quite a strong and pretty unpleasant withdrawal effect, or can on them for a length of time, and involving some pretty unpleasant experiences, vomiting, weepiness, irritability, vivid dreams, electric shock sensations in limbs, and so on, stuff that I'm sure you'll be very familiar with. So I think people need to be aware of that. So efficacy and the side effects and the likely reactions to withdrawal after long-term use. Just the third thing for an informed consent is the mode of action. They're trying to get an understanding of how these things actually work. And I'm particularly drawn to Joanne Moncrief, the London psychiatrist, who's talked about the different mechanisms of action and talks about disease-centered. And just to quickly explain that for your listeners, but going to Joanne Moncrief, that disease-centered action is what's tended to be sold to people over the last couple of decades as the mode of action. It's the reversing biochemical imbalances and that kind of thing. This idea that the drugs act in that way. When Moncrief argues quite persuasively, in my view, that that's not really the way that they act. It's a drug-centered action that actually causes an abnormal brain state, but that abnormal brain state might well be preferable to what the person's experiencing. So I think some of the common examples that's often used is, a little bit like if you're feeling socially anxious before meeting new people, that you might decide to have a couple of drinks of alcohol, which might well work, and you'll feel calmer, and it might give you a bit more confidence to interact. But the alcohol's created an abnormal mental state, not sort of balanced the chemicals within the brain. So I think that kind of distinction is a really interesting one, and I know it's contentious. I think I know my psychiatry colleagues, and some of them would argue about that, but it seems quite a useful way of looking at how drugs operate and why at times they might be beneficial.
Thank you, Gary. That's really useful. We do need to be cautious and recognise that there may be benefits for people, even if that is just a placebo effect. That's something that we should support, but we should also perhaps try to ensure that drugs are not the first line of treatment turned to in each and every case.
Yeah, I think that's right. And if people are given enough information to be able to make a choice, then of course I'd respect that and wouldn't try and dissuade them from it. But it's just sad, I think, that over the decades people haven't had that information, and the information they have been given has been rather a partisan one that's around, these drugs are restoring balance, they are counteracting biochemical imbalances in the brain and restoring harmony. And of course, the analogy of diabetes and insulin, isn't it? You're suffering with a mental illness, and these drugs will cure it by giving you the chemical that you're lacking. It's that kind of dubious kind of rationale that I think has been fed to a lot of people. over the last couple of decades or so. And it'd be good if we could give them information that would reverse that.
I agree, thank you. And you're certainly helping me to do that as part of the podcast. It is important to remind people that these myths and stories are just that and not the same as evidence-based medical science. I also wanted to ask Gary, you've said in past articles that I've read that the Western psychiatric approach has failed. What would we need to do to improve treatment for those who struggle with their mental health?
That's a good question, and it's a big one as well, isn't it? And of course, I'd strive for a paradigm shift away from illness like any other approaches to human suffering. But what that would involve, I think, would be changes at multiple levels within our communities and our societies, and not just in the kind of mental health arena. Because I guess one of the most contentious things I suggest in the book, which I know the NHS is a very cherished organisation, and it's one that I cherish deeply as well for my physical ailments. But I'm very strongly of the view that we should move away from having the NHS as the lead provider for mental health problems, mainly because I just think the culture is so illness orientated that it is very difficult for it to take on board radically different approaches. But overall, James, I think we need a multi-level approach. Maybe shift the focus on to trying to promote well-being, which is to me is a much broader construct rather than this focus on countering so-called mental illness, whatever that is. And I think a multi-level approach would involve quite a lot of political and economic changes as well to counter some of the things that we know make a significant contribution to mental health difficulties. Things like poverty, homelessness, discrimination, inequality, childhood neglect and trauma. I do think we need to kind of change the way we allocate resources to try and address those kinds of things much more effectively than we do at the moment. So in a nutshell, I think a paradigm shift for me would get us to a point where it isn't just about, and maybe not even mainly about, what the service is for mental health problems. And that's important, but that's part of it. I think it's about this change in society really, and looking at tackling some of these sources of human suffering and try and counter those, which I think would have a significant impact. I'd also tend to focus more services on trauma as well. I think not always, but I think often people who are struggling in the here and now have often had traumatic experiences of one sort or another, sometimes multiple traumatic experiences, and I think services for tackling those are really important. And a much more socially focused, less technological service. I think there is a role, as I've said, for medication somewhere, and I think there is a role for a kind of formal talking therapies as well. Bedrock, needs to be a much more socially focused, less technological service involving things like peer support and normalising kind of approaches such as those espoused by the Hearing Voices Network. Those kinds of things that are very much led, or at least service users have a central role in helping other people with similar problems. So those range of things I would see for the future. And my very final point, if I may, James, and that the other area that I'm very passionate about, I think does need to change, is the Mental Health Act. We do seem to all collude with the Mental Health Act, and to me it is a real engine room for a lot of discrimination and a lot that's wrong, a lot of stigma, and a lot of the things that are wrong with our current system. So I would like to see, I suppose I call it in the book, a collective scream of disapproval. I'd love to see that around the Mental Health Act, because the more I think about it, the more I see it as a fundamentally discriminatory, really, legalised discrimination. And I do feel that needs to be addressed. Well, I know I'm probably getting off topic a little bit there, but I do think there's there's some good work as well in pockets going on around alternatives to the Mental Health Act that would be better.
Thank you. That was really clear, and it's not off topic at all, because clearly what's in the Mental Health Act contributes very strongly to the medicalisation of distress and leads to not giving the patient the chance to be invested in their own recovery and taking control away from a patient with compulsory treatment and forcible detention or administration of drugs.
Yes, that's right, James. And when you think about the bottom line criteria for coercion, for actual sectioning people, all you need is for somebody to identify you as having a mental disorder, again, whatever that is, and deemed to be at risk. There's nothing in the Mental Health Act that automatically insists on you having to look at decision-making capacity or anything like that. If it's assessed risk and you're deemed to have a mental disorder, one can be incarcerated against your will, even when you've not committed a crime. And to me, that seems pretty discriminatory. I know Jackie Dillon talks about mental health being the last great civil rights movement, and I have some sympathy with that. And risk, another one of my areas that I feel passionate about, the way mental health and psychiatry approaches risk is quite perverse, and professionals spending chunks of their time doing comprehensive risk assessments, which the evidence suggests are at best only slightly better than guesswork. They're not, so two very dubious concepts that can result in somebody losing their liberty seems to me to be a fundamental problem with the current system.
Yes, that's right. And certainly the power that the Mental Health Act vests in people who we hope have our best interests at heart means that it shouldn't go unchallenged from time to time. Gary, thank you so much for your time today. I'm really glad that we could talk about these issues together.
No, sorry, thank you.
I'm so grateful to Dr. Sidley for giving up his time to talk to me for the podcast, and I'm sure you found the discussion fascinating. As a reminder, Gary's book Tales from the Madhouse is available now and well worth your time. It's a cracking read. Feedback. Please get in touch. I'd love to hear from you. You can email me on feedback@jfmoore.co.uk. Finally, if you're struggling with withdrawal yourself and don't know where to turn, there are some excellent resources listed on my website, jfmoore.co.uk. Please go and have a look.
Please do not increase, decrease, or stop your psychoactive prescription medication without the advice and support of a medical or mental health professional.
Thank you so much for listening, and until next time, take care.
Thank you so much for listening to Let's Talk Withdrawal. Come back next week for more news and views. If you enjoyed this podcast, please leave a review and subscribe in iTunes.